It's very fascinating to do what we've been doing for the past 10 years, especially as we do not at all believe in the so-called aging challenge. The aging Europe is not primarily a challenge, it's a success story. Because the reason we have so many old elderly people in Europe today compared with 15 years ago, it's largely due to the success of modern healthcare. And growing old might not be entirely pleasant, but is vastly superior to the alternative. So that is why we think it's very meaningful to actually measure performance of healthcare as it becomes a better industry year by year. And this is what we do. Since 2004, we've been producing comparisons of healthcare systems. This is not the complete list, but it's a fairly representative sample. And there are some patterns that are, of the 10 years, we can fairly safely say that some of the patterns are real trends. And my next slide will be, what are these trends that we see over 10 years? The first, we think, is the most important, especially after all the brouhaha about the financial crisis since September of 2008. And that is, treatment results in European healthcare keep improving. Do not let anybody tell you otherwise. Healthcare is becoming better all over. That applies also to finance crisis-stricken countries such as Southern Europe or the Baltic states. It becomes better and better all the time. With one modification, what we've been seeing in the past 2 years, more clearly than we saw before, is an increasing difference between wealthy countries in Europe and less wealthy countries. For the first 5, 6, 7 years, we did not see much of an equity gap in Europe. But as you will see in later slides, in the 2014 index, we see that more clearly than ever before. And the equity gap is mainly created by treatment results improving faster in wealthy countries than they do in less wealthy countries. The most obvious austerity measure sign we see is savings on pharmaceuticals, and that's really, really typical for the public sector. Because the public sector is usually fairly generous about allowing itself to have staff, but very restrictive on external expenditure. And saving on drugs superficially doesn't hit anybody poor, because you're saving on the revenues of rich multinational American companies. So that's a very obvious trend. Some of the patterns are remarkably stable over time, including one area in the index which is not wealth dependent, and that is accessibility or waiting times. And this, as you will see, not least from the Macedonian example today, waiting times have absolutely nothing to do with resources. Waiting times in healthcare are a mental condition affecting healthcare administrators and professionals. And you'll see the mathematical evidence for that in this later slide. Also, what is clearer this year than ever is the countries that we've now coined the phrase big beverage, and big beverage, that's the UK, Italy and Spain, just cannot keep up with the Bismarck-based healthcare systems of Germany, France, Austria, Netherlands, etc. So there is a fundamental model problem in the beverage system, particularly for big countries, There are beverage countries that do well, but they invariably have less than 10 million inhabitants. And this is what the product looks like. As usual, it consists of indicators grouped in subdisciplines. We have the same 6 subdisciplines as we had last year. You'll see in the next slide which they are. And we have a very simple scoring system of traffic light scores, green meaning good, yellow meaning intermediate, and red meaning less good. The hand symbols are there for these things to survive being copied into black and white. We also have a couple of special scores, one not available, where you see poor Bosnia-Herzegovina got a lot of not availables for the first 2 subdisciplines, and the not available counts as a red score, meaning getting 1 point for a red score, 2 for a yellow, and 3 for a green. You also see here what the even more rarer score, not applicable, such as for free choice of caregiver in the European Union. And that is inserted not to stigmatize non-EU countries, because they can't very well be expected to have free choice of caregiver in the European Union, which is why they get a not applicable score, which counts as a yellow. There's also a not applicable score for another reason, and that is on the indicator, is there a publicly available catalogue of hospital treatment results. So Iceland and Malta get a not applicable because they only really have one proper hospital in each island. So there's really no point in Malta or Iceland producing hospital comparisons. So they get a not applicable for that also. And there's actually an additional score which does not appear. This is a small corner of the index. The entire index this year has 36 countries plus Scotland on 48 indicators. The number of squares in the scoring matrix is easy to remember. It's 1776, which is easy to remember for anybody familiar with American history. And there are actually 4 purple scores. And the purple scores are awarded on the abortion indicator to countries severely restricting or banning abortion. And these are the subdisciplines, and a country scoring all green on all 48 indicators could get 1,000 points, and the weights in the middle column here is the contribution of an all green score on that subdiscipline. And as you see, the heaviest weighted subdisciplines are outcomes, the same as treatment results, and accessibility. And the reason they have the highest weight, and that is a matter of principle for the Health Consumer Powerhouse, but it's based on the fact that there are so many patient surveys asking patients what are the most important aspects of a healthcare system. And even in countries like Germany and Belgium, where waiting lists essentially do not exist, patients come back with the same reply. It's 1, my chances of getting well, and 2, accessibility. So that's the reason we have given those the highest weight. And you see what countries are doing well on the respective subdisciplines. The reason Belgium, Switzerland are in green on waiting times is they actually score all green, meaning all 6 waiting time indicators, they have a green score. The Netherlands and Sweden do score green on range and reach of services provided. Range and reach of services are there because there are significant differences as to what is included in public healthcare systems in different countries. And then I need to take the opportunity to say that our index measures only what's available through the typical public sector patient in a country, for the reason that healthcare is essentially an unregulated industry, in the sense that people with money can buy superior healthcare services in any country on the planet except Canada. So if we would include services available to wealthy people by forking out their own money, that would trivialize the whole exercise. So we include, therefore we have this range and reach of services subdiscipline. And I warned you at the beginning, this is a boring exercise. And it becomes more boring for every year. Because we have really tried to invent new indicators, and as you saw, we don't only make the Euro Health Consumer Index, we publish the Diabetes Index and the HIV Index and the Pancreatic Cancer Index and the God knows what index, and we just can't get rid of the Netherlands from the top 3. And God knows we've tried. It was really, really horrible when we did the diabetes index last September, and it looked as if we would have the same boring result again with the Netherlands number 1 and Denmark number 2, because Denmark tends to be number 2 very frequently, when Sweden, thank God, actually edged past on the power of having data for everything, because we're the only country having had a diabetes registry for more than 20 years. So the Netherlands only got a silver medal in that index. So it's nice to see that it sometimes does happen. This year, we thought it was becoming exciting last year because Switzerland, when we had eliminated all the not availables for Switzerland, because Switzerland has a funny statistical system nationwide because of all the cantons, and also the attitude that the Swiss don't keep statistics on anything that if there is not a law obliging them to keep statistics on something. Professional interest doesn't appear in Swiss statistics. So last year, the margin between the Netherlands and Switzerland was only 19 points, and we hope, oh, this might be getting exciting. This year it's 43 points again. And the only reason at 898 points, the Netherlands did not break the 900 barrier, because we sort of were looking forward to that, was the only possible weak part we can identify, and that was on tobacco control, because the Dutch are quite rather liberal on tobacco control. So when the final results from the 2013 tobacco control scales were inserted, the Dutch dropped from 902 to the final 898 points, but that's still really, really good. And the question is, what can the rest of Europe learn? What we think is interesting is what we call chaos systems, meaning systems where healthcare essentially is run by medical professionals in interaction with patients, with very little central planning. Meaning systems where patients essentially are free to pop up anywhere in the system, to seek care where they feel like it or where somebody has told them that it's a good thing, seems to be doing better than centrally planned systems. The thing is, chaos has to be managed also, but the Netherlands seem to be doing that very, very well, with just the right amount of central planning inserted, and in combination with giving patients choice and competition. But as I was just saying, doing that and just releasing the system and believing that it will manage itself is an illusion. It doesn't. And the Netherlands haven't done that. There's still a decent amount of central control, grandfather function, exerting some central control. And the question is, what could the improvement potential be? And we used to say, well, it's obvious the Dutch have a waiting time problem, which is the main reason why a significant number of Dutch people seek care in Belgium. And we can't really say that anymore, even though the only subdisciplines where the Netherlands loses a significant points is waiting times, 188 out of a maximum of 225, but that's still pretty good, because some of the Dutch waiting time problems have been rectified. And the Netherlands actually tops 4 of the 6 subdisciplines, which is unique. We never saw that before. So we don't really know what to do about you guys. But we'll have to invent some really exotic indicators next year. It's also interesting to see the value for money analysis, and the value for money model is not really sophisticated. It's the scores adjusted according to the square root of healthcare spend per capita, and the reason for the square root is that a healthcare dollar buys you a lot more healthcare in a country where a nurse has a salary of $400 a month compared with where she makes $4,000 a month. And the model, as I say, is not too sophisticated. So a country like Macedonia, which is the rather modest healthcare spend, when they do something, as you will soon hear what they did, they are unstoppable in an analysis like that. But still, you see some Albania too, because their healthcare spend is so small that as soon as they start getting points, and Albania does get points for not having waiting times, among other things, they come high up. But some countries, like Estonia, Finland, the Czech Republic, Iceland, and Croatia, invariably show up. And you see the Netherlands fairly high up in this analysis also, in spite of the fact that what happens when we present like this in other parts of Europe, the usual reaction we get when we present the index about the Netherlands being number one is ha 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 ha, but their system is very, very expensive. And we'll show you why the system is expensive, because it is. If you look at the total healthcare spend per capita, it's the same as it usually is. You have the three rich bastards of Europe, meaning Luxembourg, Switzerland, and Norway at the top, because they have more money than anybody else. And then after that, the Netherlands and Austria. And what is very, very important to say is that has nothing, as far as we know, to do with the insurance model of the Netherlands, or whether a country is Beveridge or Bismarck, because administrative things like that don't really have a big effect on total costs. Total cost of running a healthcare system or a corporation is dependent on how do you actually run your operations. And what the Netherlands does is allow itself a great amount of inpatient care. And having a very large proportion of inpatient care is what we in Health Consumer Powerhouse have named the structural antiquity. Because being admitted into hospital to cure a condition is ancient. Back in the 90s, I was one of the pioneers having to do cost cutting in healthcare. And I still remember preaching the gospel about being admitted into hospital is not something you should strive for. It's something to be avoided whenever possible. Because being treated with modern, less invasive outpatient procedures is not only cheaper for the system, it's a lot better for the patient. But as you see, there are some countries that still have this old structure with a very high proportion of inpatient care. As I was mentioning, the Netherlands is one of them. That is better. The Netherlands is one of them. Switzerland, Norway. And in our opinion, if the Dutch, Swiss, and Norwegians like to be in hospital, well, fine, because they can afford it. It's nobody else's problem. It's stupid, but it's nobody else's problem. But countries that should get support on changing, reforming their healthcare structure are places like Romania, Bulgaria, and Albania that have even more, a higher proportion of inpatient care, and they can't afford it. So somebody should assist, like the European Union should assist them in reforming their healthcare structure towards less inpatient care, because they need all the cost savings they can get. And just to tell you how much the savings potential is, if the Netherlands would have the same care structure as Sweden, the savings would be to the order of 8 billion a year. Meaning the relatively high Dutch costs, as we are being told, ha ha ha, the Dutch is so expensive. It's because you allow yourself that structure, which is fine as long as you can afford it. So here we get to something which has nothing to do with money, and that's accessibility. And Europe is waiting time territory, that's the red countries, and non-waiting time territory, the green countries. There's a change. Last year, all of Scandinavia was waiting time territories, and now everybody said Sweden has made dramatic improvements on waiting times, while Sweden and Ireland are still the two worst places in Europe for access to healthcare. I hope you heard that, because neither Sweden nor Ireland are particularly poor countries. And you also see a couple of places of excellence with having not very much money and with very different explanations. The Albanians have never understood that you're supposed to have waiting times in healthcare, so they don't have them. And Macedonia actually did something, which you'll hear about later. But there is absolutely no financial correlation or resource correlation. This is, the yellow bars are the number of visits to doctor per capita, and the broad, differently colored bars are number of doctors per capita. You see there is absolutely no relationship between the number of visits to doctor per capita and how many doctors you've got. You have cultural differences like the Czech, Hungarians, and Slovaks, who are used to going to the doctor very frequently, and they do. You have the green broad bars are the Nordic countries, where we have the ideology that we try to keep our patients away from disturbing doctors unless they are really, really sick. And the result of that, of course, is our patients tend to clog up the waiting rooms of A&E departments in hospitals. But it has nothing to do with money, and I promised you the mathematical proof, and here it is. This is the correlation between accessibility scores in our index and healthcare spend per capita. And to those who don't suffer from a professional deformity of having to work with R values, I can tell you that an R value below 50% essentially tells you there's no significant correlation. The funny thing here is the outliers, countries far away from that line, the Swiss and the Belgians scoring full have excellent accessibility, but here you see Albania and Macedonia scoring almost as high, with the healthcare spend being one-fifth of that of the Swiss or the Belgians. You also see here countries with a very low accessibility score who are not really poor. But this is the mathematical proof that accessibility to healthcare is not financially related. I have to warn you about the next slide. You're not supposed to see the details in it. You're supposed to see the big picture. Because this is the trends and line since we started for all 36 countries. And what you could see here is the Netherlands pulling ahead. You here have a group of wealthy countries. Then there's a significant gap, 3 more wealthy countries. But we did prepare a slightly less complicated picture to show you what I was mentioning in the beginning. We see an equity gap which is clearer this year than it used to be. Apart from the Netherlands being in supreme top, we now have 8 more countries, all in Western Europe, all scoring more than 800 points, which is also unique. We never saw that before. And those are all financially stable countries. Then we have 3 more Western European countries not quite making it for various reasons. They are Austria, France, and Sweden. Austria not quite making it because it would help if Austrian doctors actually were present in the afternoons in the hospitals instead of running their private clinics, and Sweden because of our absolutely stupid waiting time ideology. And then we have a 40% gap to where you start finding less affluent countries and the big beverage countries like the UK, Italy, or Spain. And unfortunately, less affluent countries aggregating at the bottom. And this is largely due to treatment results having high weight in the index, and treatment results, keep improving. This is a new novel indicator which is mathematically a little bit difficult to understand. The length of these bars reflect the steepness of the trend line for cardiac deaths. The more dramatic the decline of cardiac deaths has been over the past 10 years in a country, the longer that bar. And when we did this exercise and we got Denmark at the top, we got more confident because as a Swede, I know that Danish cardiac care used to be inferior to Swedish cardiac care until the last 5 years when the Danish really reformed. and did away with our stupid 16 counties, we still have our stupid 21 counties. So Denmark has made a dramatic decrease in cardiac care, and we would argue that this reflects the standard of healthcare in countries. This is not lifestyle changes, and the reason we can say this is we did work with the diabetes index, and the gospel about diabetes care says that there is a diabetes epidemic in Europe with diabetes prevalence increasing just because of lifestyle not improving, meaning people eating more, drinking more, exercising less, etc. The only lifestyle factor that would contribute is smoking is going down in most places, but smoking is not a primary cause for heart disease anyway. And as I was saying, treatment results keep improving. When we did this the first time, we had 9 green, and we've kept the same cutoffs. And personally, I'm very much in love with this indicator, because if we would pick one single indicator out of the 48 to reflect the quality of a healthcare system, we would pick infant mortality, because it says so much about such a very large part of the healthcare system. And as you see now, there are many, many countries below the 4, which has been the cutoff for a green ever since we started. Interestingly, you have a country like Lithuania ahead of the UK, or at least ahead of England for infant mortality. And Lithuania and Latvia have made dramatic reductions of infant mortality exactly between 2008 and 2013, when they were hit every way as badly by the financial crisis as was Greece or Italy or Portugal. So this is improving almost everywhere, with the sad exception of Romania. And we don't really know. Romania stays high and doesn't really improve. So if the EU sends consultants to help the Romanians change their care structure, they could look into this also. So money does buy you better treatment results. So this is the correlation between outcomes and spending, and you see a correlation of 84%, which is as good as you are likely to get in anything in the public sector because of data quality. And wealthy countries do have better outcomes, but not quite. And this is a very obvious illustration of why we say big beverage don't really make it. There's no reason why Italy or Spain or the UK should have worse treatment results than the Central Europeans, but they do. And this is very, very constant, even though we do modify indicators from time to time. And there's no way around this. And there are several reasons why wealthy countries have better treatment results. The obvious is they can afford to hire more staff, more qualified staff, and they can afford to invest in radiation therapy and other expensive treatments, not to speak of expensive drugs. But there's one other reason which is frequently overlooked. This is what we call the level of attention to the problem indicator. And the example chosen here is the level of attention to the problem giving to heart disease by comparing the ratio of hospital discharges or admissions over deaths. That's the number on the y-axis. And a country having a very high ratio, that means admits a lot of patients for every patient that has the problem. Or another way of saying it, they admit people on weaker indications. And the Swiss and the Luxembourgians and the Swiss and the Dutch can afford to do that. This is very typical. You see rich countries being high. That's Norway suffering from the Scandinavian attitude of keeping people away from the doctor until we're almost dead. There is a decent correlation. It's not strong, but anyway, there is. But then we see funny things like Greece. Why does it do this? So, Greece has a very, very high rate of admissions. And after all the reports about Greece Greek healthcare breaking down and Greek economy breaking down and the election results the day before yesterday, the obvious question becomes, who is paying for this? Because that is extremely costly. It's normally, it's a pattern normally as I've seen in Luxembourg and Switzerland. And the Greeks somehow still do it. It seems to us that Greek hospitals might have press gangs roaming the streets of Athens and other places, kidnapping people into hospital, but still, who is paying for it? It's a big mystery. Just as there's a big mystery on drug spending in Greece, this is as late as 2012, 4 years into the financial crisis, and Greece still has the third highest per capita drug spend in monetary value in Europe. Who is paying for all that? We know that ideologically, this coincides with generics being a bad word in Greece. If you have an argument with your best friend in another country, you could say, "Are you stupid or what?" In Athens, if there's an argument in the cafe, the equivalent argument is, "Are you taking generic drugs?" And it seems that the healthcare spending pattern has very little to do with rational causes. But on the other hand, we do see some effects. Greece was traditionally a very quick country at adopting new, expensive, sophisticated drugs. 5 years ago, we chose these drugs because they actually really work. Not all innovative drugs from the industry are as fantastic as the industry claims, but these arthritis medication really are. And normally Greece would have been up there with the typical quick adopters like Denmark. But it isn't. And that is definitely an effect of the financial crisis. Short comment on England and Scotland. We are being sponsored to separate out Scotland, and that's really a pity because we're using a system which is designed to detect differences between 36 European countries. So it's not really surprising that we don't see huge differences between England and Scotland because the two countries are basically the same. There's also, if we do the same exercise on England, there are bigger differences between regions of England than there are between the English average and Scotland. So we don't see much difference. And if we wanted to see a difference within one country, Italy would probably give the perfect example. If we put Lombardy against Calabria, they have the biggest socioeconomic difference inside one European country of any country. The GDP per capita of Lombardy being 3 times that of Calabria, and you don't see a difference like that inside any other European country. But we do see some differences between England and Scotland. Scotland does have a 10% higher healthcare spend per capita, which is a big thing in the British debate. The tragedy is a 10% spending difference in the public sector is not much. In private industry, 10% is a lot, but in the public sector, we frequently see 30% spending difference with no effect. And also, the 10% spending difference could be justified because the public health situation of Scotland is worse than that of England. More heart disease, more drinking, more smoking. So for once, that 10% could actually be logical. As I said, the two systems are essentially the same, and this year's result is Scotland 710, England 718, which is not really a significant difference. Where we see differences, Scotland has some waiting times that are less bad than the English, because England is definitely waiting time territory. What we think is sad is the UK got a green from the very start on the Dr. Foster indicator, meaning being the first country to publish hospital treatment results, so you could go on the internet and tell the ambulance driver what hospital to go to based on their treatment results. Scotland has abolished that, while England has developed it further into NHS choices and is now publishing data for individual doctors. But to conclude, this would not only apply to healthcare. Having separate sets of bureaucrats very, very rarely makes a difference for anything in any human activity. We are looking at abortions as an indicator, as I was saying in the beginning, and this is how we scored the abortion indicator, meaning we support the Estrella report that came out the autumn of 2013 saying that abortion should be the right for women in the EU to choose. But it's not a good idea to use abortion as a contraceptive. And you see the countries getting a red. They are all Eastern European countries having close to 50 abortions per 100 births, and that is a Soviet Union tradition. Russia, as late as the mid-90s, had 160 abortions per 100 births, and they still have more than 90. The only other country appearing at this end is Sweden, which we believe is a result of this policy of keeping people away from the doctor unless they are really sick. Swedish girls and ladies don't get the advice and support they should to use more intelligent contraceptives or advice about side effects of the pill or whatever it is, because we have a funny system effect where Sweden appears in that group, and we shouldn't. And we still give Ireland the purple, even though they claim that abortion is not totally banned anymore. The Irish abortion law says a woman can get an abortion if her health is at risk, including at risk from suicide. And the problem we see with that is getting an abortion in Ireland is connected with appearing in front of a panel that could consist of people like me, meaning fat males in their 60s, to explain why they should be given an abortion. And we don't think that agrees with the Estrella report right to free abortion in the European Union. I'll finally show you, getting to the end, why this is interesting. This is the 2013 indicator on use of antibiotics, and as you see, we score it on the philosophy that a high per capita use is bad, because over-prescribed against infections like the one I'm suffering from right now, and antibiotics don't help. So in 2013, we used IMS health data, meaning these are pharmacy sales data. And you see what countries appearing at the top: the British Isles, France, and France is at the top for any drug consumption data because the French eat a lot of drugs for some reason, and Romania. And in 2014, we found a new data source, a WHO report on use of antibiotics that came out in 2014. And suddenly you see Romania down here, the British Isles also down here. So as this indicator has a fairly low weight as an experiment, we decided we switch to use this data instead. The thing is, we actually don't believe this. This is based on wholesaler reported drug sales data as opposed to the previous, which is pharmacy reported. The thing is, this map, this data correlates very lousily with resistant infection data. But these correlate very well with resistant infection data, because that's precisely what you should expect. A country that has a very high use of antibiotics is begging for a resistant infection problem. But this is just to show how interesting life can be, making an index. Two very reliable data sources saying more or less opposite things about such a simple indicator as antibiotics consumption. Thank you very much. This is where I stop.